It gives me great pleasure to introduce Professor Brigitte Farou, who's a professor in pulmonology, and she's head of the Pediatric and Non-Invasive Ventilation and Sleep Unit at the Necker University Hospital in Paris, France. Looking at what happens in CPAP and NIV failure, what solutions have you used in the case of CPAP or NIV failure?
So first, it's different in any patient. So it's a very individualized strategy that requires a multidisciplinary evaluation. So I've grouped them very schematically into CPAP and NIV. If there is CPAP failure, according to the underlying disease or the reason for the patient to need CPAP, you have to revise previous therapeutic option. Of course, if you have an obese child, you have to reconsider weight loss. However, this is very difficult and rarely obtained. Also, you can discuss with the maxillofacial surgeons the possibility of rapid maxillary expansion or mandibular effacement devices if there is any abnormality of the maxilla or the mandible. You can also discuss surgery, again in selected patients, with the maxillofacial team and the orthodontics and the neurosurgeon, mandibular destruction, osteogenesis, or craniofacial surgery. We had some children who did not accept or were not tolerant to CPAP, and we proposed high flow nasal cannula. And among 8 children, 5 accepted the high flow, were extremely compliant, and had the normalization of polygraphy with high flow nasal cannula. So it can be an option. However, of the 8 patients, 3 adolescents with Down syndrome who had very severe neurocognitive impairment and a total lack of adherence, we were not able to make them accept the high flow nasal cannula. And the last solution is, of course, the tracheostomy. For NIV, it's more difficult to find alternative solutions because those patients mostly have neuromuscular disease, and we know that, of course, we have innovative treatments, but they are insufficiently efficient to reverse the respiratory muscle weakness at the moment. So the only solution is delay the decision of tracheostomy by daytime mouthpiece ventilation. And then the last solution will be a tracheostomy, which has to be carefully discussed with the patient and the family.
Yeah, and I just wondered what your thoughts were. Sometimes you offer non-invasive treatment and they're not at the point of needing tracheostomy and they refuse it. Do you revisit that situation and again, if there is the scope for you to try before them sort of crashing into ventilatory failure?
So I say our door is never closed. So I think that the patients must have the most clear and transparent information. There must be a complete confidence and clear, open discussion between the doctor and the NIV team, the patient and the family. We see quite sometimes that there are adolescents who refuse NIV or refuse a tracheostomy, but they can change. They can change their mind. So I say if they change, we can come back several months later or 1 year later, because patients and family are able to change their mind.
So I'd like to thank you so much for spending the time this afternoon to talk through what the differences are between CPAP and NIV, when to start, settings, and looking at trajectory of how long patients would need it. I think anyone watching this will have got a wealth of information from you. So thank you so much, Professor Farooq, for your time.
It was my pleasure. Thank you very much.